Welcome everybody to the Home Health Outlook webinar. I'm Joyce Pomakinwa, a reporter at Home Healthcare News. Before we dive in, I'd like to cover a few housekeeping items for today. We welcome you to download the slides and additional resources using the resources widget on your screen. We welcome questions throughout the webinar, so please submit your questions and we'll try to reserve time to get to as many as we can. This webinar will also be available on demand and the recording will be emailed to all of you tomorrow. So to get started, I'm thrilled to be joined by three panelists today, but before I introduce them, I'd like to thank our sponsor, CareXM. Today, we will be hearing from Michael Johnson, who is the practice president for home health at Bayada Home Health Care, which is one of the largest home health providers in the country. And in addition to home health, the company provides a variety of other home-based care services. We will also be joined by Dan Savitt, who is the president and CEO of VNS Health, the largest not-for-profit home and community-based organization in New York, and it is also one of the largest in the nation as well. And finally, we will hear from Silu, who is the CEO of CareXM, a triage technology that bolsters the capabilities of internal care teams. So thank you all for joining us today. Let's jump into the conversation. So I want to throw this out to all of the panelists. Before we jump into 2024, I think it's always important to look back. I want to ask each of you, what were the major trends or storylines that shaped the year for your respective organizations? And how would you categorize the year as a whole? How about we start with Dan, go to C, and also then finish with Michael.
Perfect, thanks. Hi, everyone. I would say for us, 2023 was a tough one. In all honesty, it was pretty tough. High demand for services in the home and community, especially around home health, but supply was low. And supply, we all know that's staffing, right? And so layered on top of that, productivity was lagging where we needed it to be as an organization. I think two things driving that: staff is still a little bit weary from COVID, actually very weary from COVID. And so we see that in our employee surveys. The ability to get around New York is still extremely difficult, and that's reflected in our productivity as well. Lots of unfunded costs and added pressure on gross margin for us. Transportation and safety top that list. You'll hear me talk about that later as well. On the good side, we had some nice movement on the managed care and our managed care contracts and partnerships. And so we saw solid improvement on the revenue per admission line. So we did see some of those offsets.
And C, I'd like to hear from you a little bit.
Thank you. And thank you, everyone. From CareXM's vantage point, we spent much of 2023 working with clients to creatively solve for those triage and patient engagement challenges that go hand in hand with some of the big things of what Dan mentioned on labor, staffing, and reimbursement pressure that sort of forms the squeeze from both ends of the equation, so to speak. We've seen a lot of creativity and hard work from agencies, small and large, to cope and adapt along with it. Some are creative, leveraging technology solutions in ways that haven't been attempted before. Some are redesigning their workflows to redistribute the workload in a more optimized way. If I were to give it a theme to the year 2023, I say it's probably similar to what Dan mentioned. It's a year of ongoing resilience and adaptation in the face of pressure.
And Michael.
I'll build a little bit on Dan's comments, but I'll start with C's comment, which is, for me, 2023 was a good year because it wasn't 22, 21, or 20. Maybe that's a simple way to put it. But to Dan's point, there is this COVID fatigue. I think we all feel it. And so that, sort of staffing challenges with what feels like almost unending demand. I mean, that's the upside. People are in the pandemic. I think the industry did a really good job of demonstrating our value in being a place to at least offload patients from the health system and do a good job with really acute patients. The thank you for that is a lot more people want services at home, and so that's great. But staffing and wage pressures continue to be a challenge for us. Overall, we've had, I'd say, a really successful year. It's just been hard. Right, so we're all a little more tired. The holidays were a little bit more important to catch up on sleep, but we're looking into 2024 with feeling good because our star ratings continue to climb. As a practice as a whole, if you combine our CCNs, we did really well on our TPS score this year. Right, so home health value-based purchasing is something that we're looking at, tracking client experience, tracking 60-day hospitalization in the OASIS. So we're feeling good about that and putting a lot of time and effort in that. I'll talk more about that later. And while doing that, figuring out how to increase revenue for us, revenue per admission, or as we look at it, revenue per visit. We've had some nice improvements there, right? Which is important given the CMS cuts that they gladly gave to us again. So, but a good year overall.
Well, thank you all three of you for that quick look back on 2023. So I want to throw this out to all three of you as well. As leaders, how are you preparing for 2024? And to break it down, what are each of your top 3 priorities? So C, maybe let's start with you and then go to Michael and then Dan.
Thank you. And as CareXM, as a business, we've sort of grown a lot in 2023 with all the growing demand for home health agency to outsource or creatively leverage technology to provide overflow support in the areas of after-hour triage operations or care coordination. We are really dealing with a lot of fulfillment of those demands going into 2024. So for us, the top 3 priority in order to support the jump in scale, first is to focus on data and analytics that can provide the clearest picture for our customers' value creation journey. Second is to really have a continued technology transformation so that we can help our customers and ourselves to deliver more with less. And I'm sure we'll hear from the panelists throughout the day that do more with less theme throughout their comments as well. And the third one is to invest in creative programs to relook at our nursing staff, how to engage them better from an incentive design to the overall workforce planning.
Yeah. And then Michael, I'd love to hear a little bit from you about priorities for this year.
Yeah, so for us in 2024 at Bayada, we look at and measure our performance across 5 pillars. For those of you that know the Quinn Studer, it's sort of that pillar framework: people, service, quality, growth, and finance. And so we always start on the left, we lean left, and then we look to the right. And so people is definitely one of our top priorities. Clinical model evolution, right around client experience and quality outcomes, and then growth. And so for the people piece, recruitment, and then probably even more so retention. We've had a pretty good success in recruiting, particularly nurses, but it's keeping folks. Is much of a problem as ever, because there's lots of opportunities. As the job market and the economy goes, so goes opportunity, and so that we've seen some of that. If you think about the triple aim, right, there's a quadruple aim for those of you that are familiar. And the quadruple aim adds employee experience, and so really focusing on the experience our employees feel, and the folks taking care of clients, but all the way through the organization. So that's one. Briefly, clinical model evolution is how do we take what we learned to be successful with PDGM and transition that to being successful with TPS, and to some degree transition that to be successful with MA expansion, given the limitations. And so we're working on how to continue to be relevant, even though there's payer pressure. And then growth is really, we'll talk about that a little bit later as well. We've got a couple different pathways for growth. One of them is really payer relationships, and so I know Dan has good insights there. So those are the 3 things that we're really focused on for 24.
Okay, and Dan, what about you?
Yeah, and for us, we spent the latter half of 23 going through an extensive 3-year strategic planning process, really across all of our business lines. In home health specifically, we have 4 objectives. I would say it's not really representative of just 24. I would say over the next 3 years, there are 4 things we're going to focus on. The first is, of course, staffing. Mike talked about this. He talked about it. This is absolutely critical. How do we, as an organization, become that employer of choice for any field clinician who wants to work in home and community-based care? So that's not an easy nut to crack, and so we're going to continue to focus on that. Related to that is really, how do we optimize our clinical resources to expand capacity? So given the resource constraint, what our mission is to serve the hardest to serve areas, what are some new and differentiated things we can do to expand our capacity? The third is really becoming a a differentiated market leader in patient experience and quality outcomes. So like, I think on a quality side, we've shown ourselves to do really well. That patient experience nut is yet to be cracked for us, and I think for a lot of folks in our industry. It aligns well with home health VBP, as you all know. So we're going to stay focused on that. Finally, for us, admin efficiency. So as we've, in our organization as a whole, we went from 14,000 employees at the beginning of 2020 to not long after that, 10,000, right? And so within that, we had a lot of work to do on admin efficiency, and we still have more work to do to make sure our support structure stays in line with the level of reimbursement.
Okay, I would like to, further touch on the labor market. I know it's something that has already come up. So I want to shift this questions to Dan and Michael. Home health operators faced a difficult labor environment in 2023. What do you anticipate the labor market looking like this year? And are you implementing any new workforce initiatives to strengthen recruitment and retention? So maybe let's start with Dan.
Okay, great. I think we all struggle with the same thing. Each market is different though. And so in our market, in New York City, we even differentiated amongst the boroughs. We have significant labor issues, and I don't expect that to change. So like all of us, we have a number of things going on, and I would divide it into new grads. And so we are partnering in unique ways with nursing schools. So many of us partner with nursing schools. It's the right thing to do. We have created a new partnership, which we're excited about, which is, as nurses roll through their program, they can specialize in home health. And so, we deliver the curriculum over the last year or so, give them a new experiences in the field so that we have better success with new grads. The other thing about new grads is we put a lot of money into our nurse residency program. We'll continue to do so, even though it's unfunded at this point. But we know how important it is to do that for new nurses, as well as anybody coming into our organization. We know that first 12 to 18 months is so critical. So a lot of the work we do is how do we keep people for those first 2 years, really help them onboard well, get up to productivity as expected, and then stay with us. Because once they hit that 2-year mark, we have really good results. And so there are a number of other things that we're doing. I won't go into those necessarily, but they just add on to that, because we just have to find ways by which we attract people to home-based care, which is really, really hard work, and then keep them, right? So the onboarding is absolutely critical.
Yeah, and I think that's really interesting. I know that when I covered this for Home Healthcare News, I remember speaking to a source saying that, a lot of new nurses don't necessarily know that home health is a pathway that they can take. So I definitely think getting there, as soon as possible and reaching these people does help build that pool of nurses. But Michael, I want to hear from you and what's going on at Bayada.
Probably some similar things to what Dan and his team are working on, and what you stated is correct. A lot of nurses, or therapists for that matter, as a PT, I had no idea what home health was when I got out of PT school. So giving them a sense that it's there. But I would add to that, even the nurses and the therapists that know it's there don't really understand what the challenge is until they're in the field, right? You're by yourself. You're completely on your own. And so there used to be a rap of, if the folks that couldn't make it in the hospitals went to home health. I'd like to challenge that, because I think the best of the best, to be a good home care therapist or nurse, you really have to be good. You've got to have a sense of confidence and so forth. So that's the challenge of helping them make that transition. So similar to Dan and his team, we're investing in further onboarding curricula. We're working with some partners in terms of upgrading the education, trying to give them a little bit more of an experiential learning process early on. So, because even all the interview process, you still can't filter out until they've had the experience. That's when you sort of know whether it works for you or it doesn't. And so helping them make that determination and then opt out, or as early as maybe possible so that they, if it's not the right fit, but upgrading the onboarding and the training and the resources, particularly focusing what we find, similar to Dan, but what we find is our inflection point is if they make it past the first year, the likelihood of them staying increases significantly. So we've been focusing on the first 365 days, at least for those new grads, or for new staff, as well as tailoring it to somebody who's got home health experience and somebody that doesn't, because those are different, and somebody who has home health experience maybe using the same documentation system or doesn't, because the needs are different. So we're trying to tailor it that way. And then I'd say the other thing, two other things. We did actually this year in keeping up with our good friends at VNS Health, we started a nurse residency as well, which has been really well received. We've got of the folks who've come into that program, we have a 97% retention rate, which is really impressive. Now that's within the first year. Let's see how long it goes, but so far that's a good. We're really excited about that investment, and that residency is available to nurses across a good portion of our footprint, Massachusetts, New Jersey, PA. So we're looking at how do we expand that. And I'd say the final, certainly not the final piece, but the one that I think is worth mentioning is trying to figure out how to reduce the documentation burden from our field clinicians. And the challenge that I've said to my team is, not that I don't care how we do it, I care very much that we do it. How do we do things that help people spend more time with people? I didn't go into PTs to spend time on my documentation and doing my notes. And home care is the most onerous documentation environment I've ever worked in. And so, that's part of the reason good clinicians leave is they're spending time with their tablet, not with the patient. And the 5 minutes more on the tablet and 5 minutes less with the patient, maybe the one signal you missed because you didn't ask the one question you didn't have time for that would have made the difference in their care. So for us, working with our EMR partner to figure out how do we make that a more seamless experience for our clinicians, I think is really important.
And I would like to stay on this topic, but approach it from a different angle. So C, as a leader on the technology side, how is your organization helping home health leaders like Dan and Michael and others when it comes to stretching the workforce that they already have?
Yeah, I'll pick up from exactly what Mike had mentioned about how do we focus on relieving the burden on our field nursing staff. We specifically focus on helping home health organizations identify opportunities in rebalancing the nursing workload related to 3 areas: after hours triage, care coordination, and a sense of proactive patient engagement before they even need to call in after hours, right? And we typically engage with customers to assess their current staffing structure related to those areas, then attempt to characterize what does the overall workload look like today for each team at different time intervals. And we often spot opportunities together to apply coordination and workflow technologies to help home health organizations run much leaner in these areas while achieving a greater surface of area of impact and engagement. The end result often is that a technology-enabled redesign triage operations, coordination operations, or patient outreach process can be achieved that actually ended up covering the same census coverage or even higher census coverage as organizations continue to grow with much more efficient labor costs. So it's a combination of services and technology, but it starts by really opening up the hood to understand where are people spending time and where's the workload really.
So I would want to switch gears, moving away from this topic. I want to talk a little bit about, access to care. Dan, this question is for you. You've talked about home health deserts, communities or markets that are struggling with capacity. How is your organization, VNS Health, addressing this?
That's great. We spend a lot of time from an advocacy standpoint at the federal and state level on this. So I'm going to start with, okay, when we say home health desert, right, we're referring to low-income communities or populations, but not just urban, right? Urban, suburban, and rural, especially our rural communities, frankly, that are hardest to staff and where more people who need home health just aren't getting it right now. So it's really important to note that patients referred to home health who receive it within 7 days, these are things that in the industry are obvious, right, are far less likely to end up back in the hospital, right? And they have lower mortality rates than those who don't get home health. And so the fact that the system can't support it today means that it's costing the nation more. And so dually eligible patients and racial and ethnic minorities are referred to home health less. So we have to take all this into account. So where there's lack of access, and oh, by the way, that lack of access happens to be in racial and ethnic minority neighborhoods, and they are much less likely to get that care they need within 7 days. And they are much more likely, and we're seeing this in our communities, to end back in the hospital, and they're at greater risk. So very acutely, we struggle in New York City in the Bronx, right? That's like one of the major areas, specifically the South Bronx. There are, 1 million people in the Bronx, right? So it's not like a small service area. And like, I would say over the last year, just to put a really fine point on it, even though it's bad enough that overall New York City, only 50% of the referrals are getting admitted into home health, it's less than a third in the Bronx. So when we talk about staffing, what are we doing? So we're talking about financial incentives, and as many of you know, those financial incentives are not reimbursed by Medicare, and certainly not reimbursed by managed care. We have to also focus on training, but we also have the added component of safe transportation, and just safety in the field for our staff. All those things we're addressing, but again, all of them are unfunded, and it's $1 million of unfunded reimbursement. So I'll end with this on this subject. From an advocacy standpoint, there are a few things that lots of things we're focused on, but what I would say is MedPAC and CMS measure access to home health services based on the number of beneficiaries living in a zip code by one or more agencies. So like if there's one or more agency in a zip code, check the box from a CMS and MedPAC standpoint. That has to change. And that's what we are advocating for, is that the measure of access and capacity is not about the number of agencies in the area, but about the ability to take on those admissions. And the second thing is Congress, MedPAC, and CMS really need to understand this crisis better from a patient perspective. And I've spent enough time in DC to know that the people making policy and setting policy don't understand the work that we all do every day, which is so hard. And as Mike said, is like the most onerous from a regulatory standpoint. And so when we come back, I'll come back to the end on this advocacy piece, but these are the things right now that we think about when it comes to home health deserts, and we're doing and actively involved in.
Okay. Before I move on from this topic, I wanted to give or Michael the opportunity to weigh in if they had any comments.
The only thing I would add, I think, Dan, you summed it up well, particularly related to the additional cost to recruit folks to underserved areas, for the extra training, for the safety measures. We're doing some of those same things. Both, North Philadelphia is a tough area to cover. So is rural Vermont. Very different geographies, but similar challenges in getting people. And those costs are not included in any reimbursement. Certainly, as Dan said, from managed care, which is now a larger percentage than it's ever been. The one thing I would add, and sort of builds a little bit on the advocacy piece that Dan mentioned, is advocacy, payer advocacy outside of CMS, right? Managed care, because there are some home health deserts simply because there are only a few payers that don't pay enough to make it worth it to send it out, even if you have the nurse. And so figuring out how to, and I do believe that enlightened payers want to take care of their communities. And so we actually have more in common with payers in terms of keeping a population of people healthy, but we oftentimes are in this battle between I don't want to pay you too much. So how do we build partnerships? Because that is a big factor in terms of access. As MA penetration increases, that's an additional concern from my perspective.
Yeah, and I'll just add, and I want to applaud both Dan and Mike for first treating this as a prioritized advocacy issue and also an operational issue. From a technology provider perspective, we're working on finding ways to extend the reach of home health agencies through virtual means, such as virtual visits, virtual remote patient monitoring, in an effort to play a role for organizations like Dan's organization to really look into additional means if they have figured out the operational, regulatory, payer-related sort of construct, how to get the right tools to get the job done. We're still on the very early end of this particular process, but it's definitely one of those things, just like what Mike said, even if you can capture some of those patients and aware of the underlying issues, what are some more cost-effective means to take care of them for those difficult to get to areas?
And if I could just interject, Joyce and Dan, I'd be interested in your perspective. See, maybe you reminded me, like, where's the opportunity here for telehealth? Because I think during the pandemic, all of a sudden realized that telehealth has some real value and actually can work incredibly well. I do not think it is the end all and the be all, but particularly in areas where it's harder to get access, the quality of care you can deliver via telehealth is actually better than you think. And right now, the funding for that is not adequate either. So I think that's another piece for us to work on. And I know there's the advocacy around that continues.
Yeah, I would
absolutely.
I would just punctuate that. And like, you can't, like, you need a therapist in the home, you need a nurse in the home. It's called home care, right? Like, we have to deliver care to the home, but what CMS is not paying for is the fact that I can supplement visits and check-ins in between virtually, but like, I'm not getting paid for that. So we've seen really good results in some of our managed care contracts where we get a case rate and then we get a value-based payment based on reductions in hospitalizations. Though that has worked well because it allows us to be much more flexible in how we deliver visits. It also holds us accountable for a longer period of time, so we can incorporate things like remote patient monitoring in addition to just doing more virtual check-ins. But the PDGM model doesn't allow us to do that, and that's another important, and I think, Mike, it's great that you said that. It's another important advocacy point for our industry, is to really like push us forward, give us more flexibility to be innovative, because this capacity challenge is not going away. And I agree, Mike, with you. The rural challenge is probably as great, if not greater, than a lot of the urban challenges that we have.
I think that this next question actually is perfect because we're already starting to touch on some of these different points. But Dan, Michael, I want to ask you both, how do you anticipate the home health payer landscape shaping up this year? There's obviously the cuts from CMS, so the Medicare Advantage conversation. And we also saw last year some home health providers be willing to walk away from Medicare Advantage because of lackluster rates. So I just want to hear your take on all of these various points.
Well, Dan, since you're a payer as well, I think you're better to go first on this. I certainly have my thoughts, but I'd love to hear what you have to say.
Oh, well, you know, overall managed care is a challenge, right? Like, we have a little bit of a unique opportunity in New York because we have such big market share. We ultimately have had to use termination as a method by which to really get people to the table. I think we have a sea change happening. So we're, as an industry, it'll be interesting to see how the environment changes with our payer, with managed care and our managed care relationships. Because I agree with Mike, like, we're trying to create these differentiated relationships, but we're going to have to see how these acquisitions by payers, frankly, how those shake out in the longer term, and what that will mean for us that aren't attached to a managed care organization. Say home health conveners continue to like be between us, the provider, and the managed care organization, and I think that complicates the payer landscape. The last thing I would say on this, I can talk for hours about this subject because it's so important and so complex, but the administrative burden of managing payer contract requirements and the multiple it's just unsustainable. And so for every managed care organization, I typically have 2 or 3 relationships, one with commercial, one with Medicaid, and one with Medicare. And so multiply, the number of managed care organizations by all their business lines, you're talking about 15 to 20 relationships and administrative complexities. And so I think, if I were to all this to say, I think the no managed care, less managed care for organizations are going to be a lever that the industry will continue to pull, because we really don't have a lot of other levers at this point.
And Michael, I'm going to throw the ball back to you. Home health payer landscape 2024. What do you think?
As interesting as ever. I mean, let's not kid ourselves with home health value-based purchasing. Whether you thought you were in a value-based model or not, you are, unless you're doing no Medicare, which then I would love to know how you're keeping yourself afloat, right? So I think that, and it was one of the predictions actually in 2023 for Home Health Care News, was that HHVBP would unlock more value-based, and I think you were absolutely correct. So we've been working with payers and having conversations for a decade about payer innovation, right? And Dan may chuckle this, a case rate, huge innovation, but it does change the landscape in terms of, tell me what the dollars are, hold me accountable for certain outcomes, and then get out of my way. And by that, I mean, take off a face-to-face requirement, reduce some of the administrative burden, because it's actually getting in the way of the outcomes that they want. And enlightened providers, I think, or payers are starting to see that. So we've had some good conversations, and just signed a large contract with a large regional national player that really gets us closer to PDGM rates, with then obviously expectations. Like, we're willing to put some things at risk, because right now we're all at risk, whether we realize it or not. The regulatory burden puts us at risk, puts our clients at risk, because it takes sometimes more than the 7 days Dan talked about to even get started in care. So in some ways, I've said this for many years now, it continues to be true. In some ways, it's the best time to be in healthcare ever, as long as you like uncertainty and ambiguity. But that's the only time things change. And so, like, you can complain about it or you can lean in. And I think there are payers now, particularly with the movement towards payer providers, the Humanas, the Optums. There are other payers that are interested in saying, hey, how can we start to get more creative? And so I think there's lots of opportunity here. And I think no more MA is not an option, because you hospital relationships, they're not gonna say, oh, you only take these 3 and you're not gonna take these 4. Like, so you've got to figure out how to make a relationship. And then the ones you can't, you really do have to make decisions about ending contracts. But interesting to say the least, but opportunity abounds, quite frankly. At least that's how I choose to look at it.
Yeah. And I know we've begun to touch on this as well, but Michael, Dan, do you see value-based care playing a bigger role in home health in 2024? And talk a little bit about that.
Well, I'll just piggyback on what Mike talked about. Like, yes, we're in value-based care. We've actually been in a up and downside risk-based arrangement with payers since 2017. So the real question is, though, do we think that's going to continue? And I would say what, as an industry, we should be trying to drive toward is one model. So since CMS has gone to a value-based model, can we just get managed care to move to that same PDGM value-based model? Then we're all aligned, right? That requires us to deliver quality, and then we have access to more dollars, and it simplifies the administrative burden on us. But the reality is, and I've said this publicly, like, it's hard as a managed care organization, it's hard to cut that value, that total cost of care value, in 50 different ways. And so you're putting your money into physicians if you're a managed care organization, right? That's where your percent of premium, your value is focused. It's primarily around physicians and around a few other areas, hospitals and other things. It is the home health side of it. Like, we are going to continue to be really adding value in terms of quality and experience and reductions in hospitalizations. And so we'll find ways to get paid for that. But I don't see a lot of shift in 24. I think we will have some shift in 24, which will start to really gain momentum as payers really figure out how to do this well with providers. And as Mike said, there is some cracking of that, but it's going to take a little bit more time.
Yeah, I would agree with that. What's interesting to me in this piece is we move towards I'll call it taking on some risk. I remember, Dan, you and I had a conversation. Home health, we're really not a risk-bearing entity, right? Because we're too far down the food chain. But if we take some risk for, you're going to get a ding. If you don't get these outcomes, you get a little less, or you get a little bit more. So that's when I say risk, that's what I'm talking about. Maybe small R versus capital R, Dan. What's interesting is like case rates. So like how do you unlock value? And the point I want to make here is, first of all, PDGM is 400 plus case rates, is basically what it is. But Medicare is case rates with a qualifier. Because if you're basically saying this is what you're going to get paid for this chunk of time, and this is the outcome we're looking for, and then you should get out of the way. But Medicare doesn't, because they won't reimburse a telehealth visit, right? So give us the opportunity to take those dollars and apply them in the way we think best to give you the outcomes you want. Maybe, for example, instead of sending the nurse or the PT for somebody who's got COPD, we buy them an air conditioner, right? You think about, so they're unbuckling some of what we can do with the dollars are the dollars. We're not going to spend more, but right now we're still dependent on a visit of a clinician in many cases to count. So I think there's opportunity to expand that way. And then the other piece for value-based purchasing that I think is going to be interesting is HHVBP. I mean, they've already gone ahead and changed some of the base metrics without even any experience in sort of how those are. And so there's a couple. I'm excited about it, but I'm a little bit worried that CMS is already moving the goalposts without our involvement, or without testing it. So the one example I'll give to finish, because as a PT, as a therapist, this one particularly important to me. They're eliminating the discharge to community metric. And the normalized composites for mobility and self-care to this discharge function score. Sounds reasonable. When you look at the discharge function score, there's about 12 different functional things that you work at, but self-care, ambulation, and feeding are not included in that. I think I'm saying that correctly. I know it's self-care and ambulation. Actually, dressing. I'm sorry, I know I was getting that wrong. Why is that such a big deal? Well, if you're in a skilled nursing facility, somebody's there to help feed and dress and help with your self-care. But when you're home, that's what we have to get people able to do. But my understanding is that metric was designed because it's similar measures in every setting, but those measures are more important in a facility setting. The ones that are most important in home health, right? Self-care, dressing, ambulation, are the ones that aren't included on it. So things like that so again, opportunity, but we just need to be engaged earlier on. We want to get this right with CMS. So not perfect, but such as it is.
And C, I want to hear from you. How is CareXM helping providers lean into value-based care opportunities in your view?
Yeah, we actually have quite a few customers looking ahead into how to rewire their operations and their payer contract relationships to be ready for this value-based future. In fact, one of whom is a classical payvider sort of structure in one of the names that Dan mentioned earlier on in all of their home health locations. What we've observed so far is that these organizations tend to have a need to first completely examine the total cost of care. I think Dan touched on that quite a bit, by deeply understanding the ground up inputs on service utilization, labor utilization, and more importantly, in between those two constructs, what are all the touch points with their patient population so that they can indeed take on more risk and deliver value. The pieces they engage with CareXM on starts with getting us involved in unpacking the key coordination points with the patient. Something as intuitive as if a patient keeps calling in the after hours or weekends for the same underlying challenge, what are the key things that we need to be doing to proactively engage them before they end up in the emergency room, right? That one touch point of navigation, very minute, but oftentimes are not these sort of discrete signal that you can see from the EMR or your claims data for that matter. What touch points should we be providing before these events happen to be providing the support for the broader coordination of care with your DME partners, with your providers in the community, even with pharmacy in the community? I personally think this is a very, very exciting and potentially very difficult to get right piece too. I resonate with Mike's earlier comment. We love the ambiguity and sort of the uncertainty ahead, because a lot of that is forcing function to really force all the players coming together to come up with more creative solution that can make us more resourceful as we adapt to a value-based future.
I would like to now talk a little bit about M&A. There was a clear slowdown in M&A activity in 2023. Michael, Dan, how do you see home health deal making shaping up in 2024?
I'll jump in initially, Dan. I mean, we've got a small team internally to sort of continue to make sure we're looking at opportunities. I think the piece for those of us that are in the business and those people who are trying to get in or thinking about getting into the business, I think the slowdown in 2023 had to do with the looming payment cut, a big portion of the looming payment cut for CMS that CMS was talking about. And what they've signaled is that whatever cut they propose over the last 2 years, they're going to implement. Because let's not kid ourselves, the cut that they were talking about last year, they cut it in half and then gave us the other half this year. So they're just dragging out. So I think that there's a question between that and the increased penetration of MA, the predictability in terms of the finance. You make an investment and you expect to return at a certain rate. The pay rates have obviously a direct impact on that. So I think the uncertainty there is slowing things down some. That said, I'm seeing a lot of activity in home health, and actually even more so outside of home health with health systems, and that's the impact that will have on us is also interesting. Just today, I live out just outside of Philadelphia. University of Pennsylvania announced the plan to buy a well-respected long-term community partner hospital in Bucks County, and this you just sort of see them day after day, and so the impact that has on home health services, because now does that interrupt our relationship and so forth, it's I don't know if it's concerning or if it's opportunity, but it's definitely there's a lot of churn that's still going on that's creating, to me, it's more noise than solution. Dan, I'd be interested in your perspective on that.
Well, we don't get involved. So Mike, you're much closer to the M&A side than we are because I would say, I think just in general, as we've looked at M&A, you're going to see activity pick up. There's a lot of capital, right? That's just been stuck as interest rates went up. There's a lot of capital that needs to be redeployed. I think home care is a place that's going to continue to be redeployed against. And so I do think there's going to be a pickup. I do think we're going to see consolidation continue. It's so important to be big in a market. And so big nationally with only small footprints isn't helpful. You want to be not only have multiple markets, but have material market share within a market. So I think it's going to continue, and I think the dollars need to get spent somewhere, and home care is a place that there's going to be focus on.
And one thing I'll add to that is folks the mom and pops who've built these home health organizations that are small and very local. I think we're starting to get more and more phone calls from folks saying, "Hey, not that we're ready to throw in the towel, but we're ready to transition, or we'd like to join a large organization." So, that's an opportunity for us. And certainly, what we look for is folks that it isn't just any warm body; it's same culture, same right location. But the smaller providers, we said PDGM was going to drive half those folks out of the market. COVID sort of muddied the waters in terms of what the impact was. I think we're starting to see some of that, and that's probably where a lot of the M&A activity is going to come from.
And I would like to hear how each of you plan to grow your respective organizations in 2024. Will that involve M&A, or will you focus on de novo locations, same store organic growth? Dan, can we start with you?
You can, because my answer is easy. It's organic, and we're not expanding our geographies. It's hard enough to work in New York State or New York City and the surrounding counties. I have no desire to compete head against Mike over across the river into New Jersey. So we're very comfortable just with all the opportunity that already sits there where there's need but not resources. We're going to focus on increasing the resources in our current market.
And Michael.
And so for us, it isn't as simple, right? Because we've got a large geography. We're looking to continue to grow. So I'd say there's sort of 4 parts to our growth strategy. One I mentioned before, which is strategic payer strategy. So it may not be growing the number of offices that we do, but the revenue that we get. So I do want to sort of recognize that. But in terms of growing physical office space and treating more clients and serving more communities, sort of three ways we're looking at it. One is de novo. Either de novos or what we call splits. So we have an office, we split the office and move to a separate territory, sort of a little bit of amoeba-like, and that's been the growth in our organization has been almost purely, the bulk of it has been de novo. We do sort of select acquisitions if the timing is right, the partner's right. So I'd say de novo and splits. We've got a strategy that we've put together in terms of beginning to really start to plan out 2 to 3 years. Where are we going to be in 3 years, and actually working towards that, because in part COVID it was responsible for some of this, but sometimes getting the regulatory approvals takes a year or more, and so de novos and startups with a little bit of a longer planning time is one. M&A, but really strategic. So right location, place we are, and we want to add, and it's the culturally aligned organization, or it's a geography that we'd like to be in because it butts up to another one, or we want to plant a flag there. So we do that. M&A is not our driving strategy; it never has been, but we see that as part of the portfolio. And the final is something that we've been in for the last 6 or 7 years, which is health system partnerships and joint venture relationships. And so that we also look for partners that are strategically aligned, both geographically where we'd like to be, and communities that are underserved, but with a really good anchor health system that's struggling with home health or hospice services, and particularly one that really is really forward thinking, because I think there's a lot that we can do in the home that wouldn't be considered sort of standard home health services. So payer strategy to grow revenue, but then in terms of growing offices and serving more clients, de novo sort of split, strategic acquisitions, and then strategic partnerships with health systems generally through joint venture relationships.
And I'm curious to hear, the ways that CareXM is aiding providers as they grow.
Yeah, over the last 2 years in particular, and we foresee this year to actually continue to accelerate this trend, which is a lot of consolidation continue to take place, similar to the dynamic Mike probably had mentioned earlier on, smaller organization needing to be aligning with bigger ones for M&A strategy grow, or even organically. As organizations start to grow, these geographic cluster or densities start to increase. There's almost inevitable opportunity to streamline or achieve economies of scale related to how you plan on-call visit labor, triage labor, some of the care coordination labor involved in that. We provide the technology for our customers to analyze those geographic clusters, the utilization of those labor, and we certainly help them augment their capacity as we run along. So by default, what we're trying to do is to leverage that on-demand virtual staffing as well as an augmentative piece, so that while customers are scaling more locations, more census, they're also achieving effectively a net savings in OpEx comparing to their status quo. That by default, hopefully, is a scaling function as you cover existing patient volume or grow the volume without linearly growing the labor cost base.
So we're getting kind of towards the end of the conversation here. So I want to make sure we touch on everything, because we've already discussed so many great topics today. So to all three of you, beyond what we have already discussed, what other trends, challenges, opportunities do you see defining home healthcare in 2024?
I can start.
Go ahead, Dan.
Yeah, I'll just start here. I think we have, as an industry, a big challenge in advocacy. So I'm just gonna lean into that. We need to come together differently at the federal level. We need we've not been effective. We just have to own up to it. We have not been effective up to this point in our ability to influence policymakers. Just flat out have not, despite the desire to do so and the need to do so. So, and not at the levels of other sectors. So we have to think about pharma, right? Physicians, right? And hospitals. They have been very effective in their efforts to lobby and shape policy. We need to have that as our North Star, and we need to come together differently as an industry of good associations, right? But we need to come together and we need to find ways to be more effective around here, around this particular component of what we do.
Yeah, I would agree. And I have two thoughts. One, I want to build on Dan's. And I could not agree with him more in terms of it's not failure it's not like we haven't put effort in, but we've not been effective for sure. And so I think both Dan and I recognize there are a lot of people trying to put effort in, but part of maybe just how we framing this. And so that's where I want to start with is, I think we need to have policymakers, we need to start presenting ourselves as a system, the system of care that we provide in the home. Right. And so I know VNS Health as well. And Joyce, in the introduction, we offer a range of home health services in the home. And so how do we, within our own organizations, help create a system of care, a continuum of care that keeps people safe at home? Home health, private duty, right, hospice. And we have the capability to do that if we don't create our own silos within our own organizations. But I think payers and policymakers see us as a post-acute, take care of them after all the important work's gotten done. We've got to figure out how to change that narrative. And some of that is just using languages. So, one of the things that we're working on, at least that I've been thinking about and we'll be introducing in our organization, is how do we start doing things, research and so forth, and function like a learning health system, right? And Dan, I know you guys have been talking about that. Your Research and Policy Institute frames out this concepts of a learning health system so that we can use similar language with policymakers and really say, hey, think about a hospital and you go to this room and this ward and you get this test. Well, when they're in the home, we're doing the same thing. And I think if we can help policymakers see us in that light, because they can't wrap their heads around. So let's go to where their heads are and think about ourselves as a system. I think that's an opportunity. And you see it with the payviders. That's what in theory, what they're trying to do is to create a holistic system. Now, whether they'll be able to do it or not is a good question. The second I want to add is a little bit more sort of practical, and that is within the post-acute realm. SNFs is a good example, where they've been impacted by COVID, payment rates and so forth. So we are seeing some of our facility-based providers starting to do things to keep people longer in their facilities that are actually making it harder for us, adding more rehab services, because the pay for the more typical SNF post-acute has been limited. So they're trying to hold on to folks longer. So by the time we get them, actually, while you think they were better, in many cases, they probably only put off hospice, for example. By the time we get them in hospice, it's a short length of stay. So it's just an example that individual actors, while well-intentioned, aren't creating systems. And I think that's how the payers and policymakers, they see us as individual actors. We got to change that.
Yeah, and I resonate very strongly with what Michael mentioned here, because building a system of care around the home seems to be a tremendous opportunity.
I want to throw a fun question out there to all three of you. What bold prediction do you have for home health in 2024? Let's start with Dan.
So here's what I would say is we will see, we don't all want to hear this, but we will see some more large acquisitions of regional or national home health providers by non-home health organizations. So we saw a couple, they're like, wow, that was like unexpected. And we don't know what that's going to look like. So I would say we might see one or two happen again. And then the flip side of that is, I've done a lot of acquisition activity in my career. I would say it also creates opportunity at the local level. So like there is opportunity when this happens to take market share as an example, or to show your partnership and double down on your partners with out in the community. So it'll be interesting to watch not only how this evolves in terms of the consolidation of home health providers and other non-home health organizations get into this business, but then what happens at the local level and how does that create opportunity for us?
See.
Yeah, and I think in terms of a quick prediction, or rather what we see every day, we think organizations will find both technical and non-technical ways to deeply engage their field staff. I think that's still the number one asset in creating that experience and quality, from automation of knowing when a nurse visit can occur to dynamically coordinating the workload and shifts. A lot of very exciting solutions are coming to the market to become that input for value-based care at a very granular level.
And Michael.
So I thought a lot about this one. So I'm going to actually go off script and say, rather than a bold prediction, I'm going to put a bold challenge out. To build back on this systems, how do we tie into language that's out there? And one of the models that I've been enamored of lately is what's referred to as age-friendly health systems. Right? It's by the IHI, the Institute for Healthcare Improvement. Right? It's the 4 M's. What matters: medication, mentation, and mobility. If you think about home health, or hospice for that matter, but home health particularly, those you could anchor around those. And again, if we start using language that the health systems are using, I think we've got to go again to where people's heads are. So my bold challenge, maybe my bold prediction, is we'll actually start doing that a little bit more, and maybe get a little bit different level of attention from policymakers. That's not going to happen in a year. I think Dan and C both can appreciate that, but I think that will help us move in that direction.
That's a great point, Mike. Common language that people understand. No one outside of home health understands home health language. And that
right.
Holds true for payers. Like, if the managed care has its own language, the problem is they own the dollars. So we have to speak their language. You can't expect them to speak ours. And so that was a really good point. Good challenge.
If all three of you could wave a magic wand and have one thing happen for home health in 2024, what would it be and why? C, let's start with you.
Yeah, first of all, I just want to thank Mike and Dan. I think I learned a ton from you all, and thinking from your perspective as well. After this conversation, I feel like every home health organization, I wish them to find an effective way to align their cost structure against the reimbursement pressure without sacrificing quality. I know this is the holy grail of any healthcare organization, but we will continue to deal with the changes and pressures. I'm very hopeful that great achievements can often be accomplished by applying what seem to be impossible, really difficult constraints initially. And this notion of building a system of care around the home, having a common language to refer to that, treating home-based care as the battlefront of healthcare, I think there's a ton of promise to that. If I can wave a wand, I almost wish to see that tomorrow.
And how about you, Michael?
Well, first of all, I like that wand, so please start waving it. And I appreciate the chance to be on the panel and with the two of you as well. I'd say the magic one I would wave, I spoke to it earlier, is reduce regulatory and documentation burden. Let people who are dedicated doing the hard work by themselves in the homes, let them spend more time with the people who need their care. Like, if we could do that, and there's every reason we should be able to do that, and we should be able to do it pretty quickly, because Medicare, CMS has the data. They know who the providers are that are doing a good job, and they know who's trying to skirt the sort of the rules. So deal with them and give the rest of us a little bit of a break, show us a little bit of trust, and you'd be surprised at what kind of good stuff we could do.
And Dan.
Yep. Thanks, Joyce. Thank you for allowing me to be on this panel. And for those that attended, you're going to see a theme in the things I talk about. Here's my magic wand. Change. I want to see a change in the way CMS scores home health. And that word score is important because that's what CMS does. They score everything and connects our value to the to how total cost of care can be lowered through the work that we do. And then not only that, recognition and scoring charts a path to take the money that we drive in lower cost of care and invest it back into home care, so we can continue to do the great work that we do and continue to innovate.
Well, that is all the time that we have for today. I'd like to thank C, Michael, Dan for joining us and sharing their insights. For more news and insights, please be sure to check out homehealthcarenews.com. And thank you all for listening today.
Thanks, Joyce.
Thanks,
everyone.
Thank you.